Good evening, and thank you for joining us. I'm Dr. Alexander Hillel, a professor in the Department of Otolaryngology, Head and Neck Surgery here at Johns Hopkins. It's really a privilege to be with you tonight to discuss a condition that's really at the very heart of my clinical work and research, idiopathic subglottic stenosis. Joining me tonight is my patient, Amy Atwell. Amy has graciously offered to share her firsthand perspective on the challenges of living with iSGS and her journey. Tonight, we will walk through what it's like to have this rare disease, from the frustrating hurdles of initial detection to the specialized care pathways we provide. I will also share some thoughts on hypotheses on what causes idiopathic subglottic stenosis and some of the latest treatment advances, including some that we've specialized at here, an endoscopic procedure using skin grafts and stents that provide lasting relief to our patients. We hope this combination of clinical insight and lived experience provides a comprehensive view of what living with idiopathic subglottic stenosis is like. These are the objectives which I described. A little bit about myself. You can see my professional journey. This is my family, my wife Janice, and our two kids, C and Sky. They're 13 and 15. And I show pictures of sailing because this is one of the good things that came out of the pandemic. And during the second summer of the pandemic, the only in-person camp here in Maryland was a sail camp. And my wife got both of our kids into a sail camp because you could be 6 feet apart and still be outside and in person. And amazingly enough, for both kids, that sail camp has really taken off into a passion for both of them, and has allowed us to really experience a new part of Maryland with the Chesapeake. Um, First, go over what subglottic stenosis is, and then some of the presenting symptoms, and then turn it over to Amy to share her experience. Um, you can see in the lower right of the slide what a picture of someone without subglottic stenosis looks like. This is a laryngoscopy image. And in this picture, that's a little higher, you can see the scar tissue that develops just below the vocal cords. And the very narrow airway here compared to the large airway that someone who doesn't have this scar tissue that develops just under the vocal cords has. These are gross photographs of a patient with a normal subglottis or trachea, and then those with subglottic stenosis and the really narrowed airway, again, seen here pretty clearly. And that limits airflow. This is a heat map showing a normal airflow on the left, and on the right, that narrowing really limits airflow, impacting breathing. What are common causes of subglottic stenosis? The most common is actually iatrogenic, and that means that we in the medical field cause it by with endotracheal tube intubation or tracheostomy tubes. A second common cause is autoimmune disease, but what I'll be talking about today is idiopathic subglottic stenosis, which represents about 15 to 20% of all cases of subglottic stenosis. And what you can see from this slide is that this is a homogeneous disease that affects women almost exclusively, and then also more specifically women of Northern European descent. And when I talk about some of the possible causes of this, I think that disease, the similarity in individual that presents with the disease is part of what we're looking into, and some potential genetic causes. As I mentioned in the intro, iSGS is a rare disease that affects less than, and I'll define a rare disease is defined a few different ways. You can think of it as a disease that affects less than 200,000 Americans, um, or the NIH defines it as 1 in 2,000 Americans, which is approximately 175,000, and that you'll see one case in 175,000 individuals. And then an extremely rare disease is one in which it affects 1 in 50,000 individuals. And that is what iSGS is. I estimate that approximately 7,000 Americans have this, and that's part of what makes it difficult to diagnose because it's not so commonly known. This is a video of an individual who presented to clinic. And before I start the video, listen to her breathing patterns because this really indicates a very severe presentation of the disease.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its half high.
And you can tell by listening to her that she can get about a word, maybe 2 words out before having to catch her breath. And in addition, when she does catch her breath, it's really a very noisy sound. And that noisy sound is stridor. Other presenting signs and symptoms, as most people thankfully don't present in that severe of a state. And the first symptoms that many experience is shortness of breath with exertion, walking uphill, say, or walking upstairs. As it progresses, and in severe cases like we just saw, there can be shortness of breath or dyspnea at rest. Throat clearing is a common symptom in iSGS, with many individuals saying they're not able to clear secretions. Stridor, as we heard, and then a number of patients have hoarseness because of the scar tissue involving the vocal cords. Diagnosis takes over 2 years on average. And during that period of time that women are presenting with, that women notice that they're short of breath, and that 2 years that it takes on average to be diagnosed, more than half are diagnosed with asthma and don't respond to inhalers. 14% will go to the emergency room because of how severe their shortness of breath is, and over 10% are hospitalized before being diagnosed. That really creates a sense of marginalization by the healthcare system. And I think that's in part because doctors are often focused on the most likely answer. And that's why so many are diagnosed with asthma, because asthma is one of the most common causes of shortness of breath. But what that leads to, unfortunately, in many cases, is that the doctors that they're seeing aren't really digging deep enough to find the actual problem. And then symptoms, in most cases, get worse and worse until patients see an ear, nose, and throat physician, or sometimes an interventional pulmonologist who have the ability to use a scope to see below the vocal cords. And that's when the scar tissue is usually identified. In some cases, sometimes a CAT scan will identify the narrowing, but more often than not, it's oftentimes missed by the radiologist. So I think at this point, I would like to turn the presentation over to Amy to hear her story.
Thank you, Dr. Lal, and good evening to everyone. You're going to sort of see on my pathway to diagnosis that I basically hit all of the points that were just went over. So my symptoms started in 2017. I was 37 years old at the time and extremely active, worked out 6 days a week, very, very active. And I started showing some shortness of breath, specifically during exercise, and that throat clearing and coughing. I put up with it as long as I could, and told myself I was just out of shape and it was nothing or a cold. And then I saw my primary care provider and was treated for asthma. I was provided some rescue inhalers and a steroid inhaler. Neither of them worked. I was tried those for 6 to 8 weeks, up to 12 weeks. I didn't have any relief. And at that point, my symptoms were worsening. I could hear myself breathe. I was taking those deep breaths in between my words. And I just was really, really coughing all the time. I also underwent allergy testing and everything came back negative. So my PCP prescribed me and referred me to a pulmonary specialist. They determined it wasn't asthma through a variety of tests, but they weren't sure what it was. So they took me off all the inhalers and then prescribed me another medication. Now we're into 2019. All of these symptoms are happening. I'm having trouble going upstairs. I can really hear myself breathing. Other people are asking me what's wrong. So at that point, I was sent for a CT of the chest, unfortunately, not the throat. And an ultrasound due to some blood work that had some elevated white blood cell counts and D dimers. I was on a regimen of antibiotics, probably 2 to 3 courses. All the blood work they did had me negative for autoimmune diseases. So my pulmonary specialist and my PCP were stumped. They did not know what it was. I thought it was all in my head at this point. But finally, I got the referral to an ENT, and this is when everything changed. So I saw an ENT outside at the Columbia location in Maryland. She did perform an endoscopy, and then she said to me, "I think I know what you have, but I'm not for sure, so I'm going to give you a referral." She also ordered a CT of my head and neck. And at that point, I was referred to Dr. Hillel. So I'll never forget the day. I saw Dr. Hillel on October 8th of 2019. It took him 3 seconds after a scope to determine that I had subglottic tracheal stenosis. At that point, I knew something was wrong. I think the hardest thing about that appointment was he told me it was chronic. I think in my head, I had thought I had something, I would take some medication or do something, and then it would go away. But he told me that may not be the case. So we scheduled my first surgery because I had a narrowing of about 75%. And then he sent me for some further testing just to see if it was autoimmune. Finally, exactly like 55% of the people, 2 years and 1 month later, I had the diagnosis. All my tests came back negative for autoimmune, and I officially had idiopathic subglottic tracheal stenosis. It has still been a journey since then. So about a week after that appointment, I had my first dilation at Johns Hopkins. The surgery went well. There was no complications. I immediately could breathe when I woke up from anesthesia. It was remarkable. That dilation actually lasted for a pretty long time until March of 2021. I started to show the signs of my airway closing again, so we did another dilation. You'll see the timeline is a little bit shorter this time. I required another dilation in May of 2022, and then again in March of 2023. It was at that time that Dr. Hillel started to discuss other options because my dilations were not lasting that long. I became part of the Everlumis trial, the clinical trial, in March to May. I didn't have any symptoms from taking any of the medication. However, the narrowing of my airway still occurred. So at that point, we decided to do the Maturin procedure, in which we took a skin graft and a stent. I had that procedure in November and the 2 follow-ups for the cleanouts and removal. And then unfortunately in January of 2024, we learned that the Maderin was not successful. So we decided to do in-office steroid injections in February 2024. Um, Unfortunately, those were not successful at all. So I had a dilation in April of 2024. And at that point, Dr. Hillel and I decided it was time to do a full resection. So I had my resection surgery in June 2024. And then I had 2 cleanouts after that in July and August of 2024. And I am so happy to report that I have been out of the operating room since August 2024. And as sad as it is, I don't see Dr. Hillel on a regular basis anymore because I can breathe. My airway is open. I truly and remarkably have my life back. And I can't thank the team at Johns Hopkins and Dr. Hillel enough. I truly, at some points along this journey, was not sure if we would get here, but we are. And so I thank everybody and appreciate everyone on this call to learn about this disease. And I will pass it back to Dr. Hillel.
Thank you, Amy. Before I move into treatment options for iSGS, I want to talk a little bit about what are some possible causes. I think I will first start by saying we don't know. The idiopathic is still correct in front of the subglottic stenosis, but we are doing everything we can to try and remove that from the title of the disease name. Well, what do we know? We know that it is driven by immune cells. We've also learned that the epithelium plays a role, and I'll talk about that based on some of our research. And the Maderin surgery, where we replace the epithelium, I think works because it creates a better barrier. And it actually brings us to a concept of the mucosal immunologic triad, which includes the interaction between epithelium, which should be a barrier, with antigens that are constantly trying to probe to enter through the epithelium or the skin. And when they do, it revs up or it stimulates the immune system. And in the case of iSGS, the immune cells are driving fibroblasts. And it's those fibroblasts that lay down the scar tissue. We're also investigating some genetic factors, and I'll present a little bit of more recent data about a specific gene that we've found has a much higher rate of mutation in iSGS patients, and actually leads to a difference in clinical outcomes as well. First, just some pictures showing what is a normal trachea. Here you can see the cartilage to the left and a very thin lamina propria layer. And the image on the right is the same depth of biopsy, but what you can see is this is all lamina propria. We haven't even gotten to the cartilage in this specimen. And this is the skin, which looks a little, or the epithelium, I should say, which looks a little more irregular than the normal specimen. And then you have this layer of inflammatory cells. And that seems to be driving the development of fibrosis, which is laid down a little bit deeper. When we take, this is a pretty immunohistochemical picture showing multiple different types of immune cells, but you can see the green cells, the red cells, and especially the yellow cells, how prevalent they are just under the skin. So again, we know that immune cells are a key part of this disease process. But why is it that primarily women are affected? And one theory, and I stress that this remains a theory, is that it is activated genes that are on the inactive X chromosome. So I'll spend a minute or two describing what happens in a normal situation. Early in embryogenesis, all of the cells in a female embryo have two X chromosomes, but one of them has to be silenced. And in each cell, it can be different about which one is silenced. And so in a normal cell, the women undergo that random silencing of one of the X chromosomes early in embryogenesis. And ideally, all of the genetic material on that chromosome is turned off. However, in this theory, the thought is that a small percentage of inactive X chromosome escapes silencing. And what this genetic material tends to do is ramp up the immune system. So again, hasn't been shown to be the case in iSGS, has been shown to be the case in a number of autoimmune diseases that preferentially affect women. And so that is one of the theories we're looking at. I mentioned the mucosal immunology triad, where this is a cartoon showing a normal subglottis with intact epithelium, and bacteria or perhaps viruses or even other antigens, even like acid reflux could be considered an antigen, is trying to get through the epithelium, but the epithelium is blocking it. However, in the leaky barrier hypothesis, what we see is that the epithelium doesn't have as tight of a barrier, and antigens can now pass through the leaky barrier of the epithelium, and could be bacteria, could be viruses that enter into what is usually an immunoprivileged location, the lamina propria. And that's what activates the immune cells that then lead to fibrosis. So this is a cartoon sort of showing the healthy epithelium on the left side and iSGS or fibrosis on the right side. And then the antigens that really, again, enter through that leaky barrier. And that has been something that we've been studying here, and have shown that the epithelium has in iSGS has an abnormal barrier, and the proteins that are critical in creating that barrier are abnormal in iSGS. One of the discoveries that we made actually involves the FUT2 protein, and I'm just going to explain that this is a protein that is key in helping epithelial cells make those tight barriers. And what we found was that in individuals with iSGS, they have a very high rate of mutation in this gene. And what we see in individuals who have that mutation, the green stain on these two upper images are individuals who do not have the mutation. And you can see that mutation is evidenced by the fluorescent green stain in both of these photos. However, those individuals who have the mutation in the FUT2 protein do not exhibit any of this protein in the epithelium. And so they have a leaky barrier. Well, I think, when we're studying things, when we're doing protein studies or studying things in vitro is one thing, but it wasn't until we looked, well, what are the clinical outcomes of patients who have iSGS, who have this mutation with a leaky barrier, and what are the clinical outcomes of those individuals, those few individuals who don't have the mutation? And that's what really opened our eyes, because what we found was when you have the mutation, you actually have a much shorter intersurgery interval than if you have normal production of that protein. So our theory is that the FUT2 protein in a mutated state is abnormal and contributes to that leaky barrier. And that is one of the avenues of research that we're currently pursuing. In my last 10 or so minutes, I'm going to talk about surgical management. And I think Amy probably had every single surgery that or procedure that she shared in her course. But when I first started 14 years ago, there were really only two traditional treatment options. There was an endoscopic excision and dilation, and then there was an open cricotracheal resection. And it's a cricotracheal resection in the case of idiopathic subglottic stenosis because the scar tissue involves the cricoid. And so part of the cricoid needs to be removed. What I have for some of these treatments are some videos in the next few slides. And then I will also have some videos or images of some of the newer treatment options that have really entered our practices over the last 10 years. And those include serial intralesional steroid injections, endoscopic wedge excision, commonly done with a CO2 laser, but sometimes other instruments are used, and then the Mattern procedure or an endoscopic resection. This is a video showing the endoscopic excision and dilation. We also inject steroid as part of this procedure. This is coming in and exposing the vocal cords. The subglottic stenosis is below just below the vocal cords, as you can see. And what will next come in is actually this is a cryoprobe. I now primarily use sharp scissors to make those cuts. After the cuts are made, we bring a balloon dilator in, and that's what really opens up the airway. And here comes the balloon. And you'll see it expand to treat the area of narrowing. And then after we dilate it, we will inject steroids. And the goal of the steroids is to reduce that inflammation and try and slow the recurrence of the scar. And here you can see a much larger airway after the procedure, which is almost of a normal caliber. This is images of that individual. You can see how small the airway is on the left, and that it's probably somewhere between 4 and 6 times the surface area at that location after dilation. What I have next are a few cartoons of a cricotracheal resection, just sort of showing images of how we isolate the cricoid, which is here, and the trachea. We'll then make cuts of the cricoid, making sure to preserve the recurrent laryngeal nerves, which are the main nerve that move our vocal cords, and then sew it back together. Well, those were the traditional options, but with an endoscopic dilation really being a low-risk surgery, but tends to treat subglottic stenosis as a chronic disease state, as we heard Amy talk about, requiring serial surgery. And a cricotracheal section is a definitive procedure that provides a permanent solution in most cases, but can result in a neck scar, loss of high pitch voice, because some of the muscles that create your high pitch in your voice are attached to the front of the cricoid. And then one of the side effects or complications can be vocal cord paralysis. So therefore, that's really the reason why these newer emerging therapies have come in. And they are sort of an endoscopic resection, an endoscopic wedge excision where most of the scar is taken out, and then in-office steroid injections. I'll begin with the endoscopic resection, and this is just a series of panels that shows the scar tissue, the initial cuts, and then shaving of the scar tissue, which is then relined with a stent which has a skin graft attached to the stent. That is left in place for 2 weeks, so individuals can breathe through the stent. The stent also acts to put pressure on the skin graft, which is adhering to that area of where the scar had previously been excised. What I have here is a shortened video showing the excision process. And we want to make sure that we remove all of the scar. And then once we do that, we'll bring in the stent, which has the skin graft attached, and that's placed. And then there's a stitch that comes across the neck to hold the stent in place for 2 weeks. After that's done, 2 weeks later, we remove the stent. And when the camera comes in after the stent is removed, you'll see that the skin graft is adherent, really almost circumferentially, and you have a normal caliber airway. Well, as Amy mentioned, there are 2 other surgeries that are part of this. And that is because the skin graft, some people use a buccal mucosa graft, which is mucosa taken from the inside of the mouth, isn't a good facsimile for the respiratory epithelium that clears secretions. And so 2 surgeries, in some cases a few more, are required to remove those secretions and then laser resurface the leg skin or buccal mucosa graft to encourage overgrowth of the respiratory epithelium. So in summary for the Mattern, it's a minimally invasive definitive surgery, which is in about 3/4 of individuals. Unfortunately, Amy was in that 25%, but in 3/4, it's successful. Up to 2/3 struggle afterwards with daily mucus management, and that is because, again, as I mentioned, the skin graft, even after the laser resurfacing, doesn't have the respiratory epithelium that does a better job of clearing mucus. And then exclusion, what I've found in those individuals who recur after the Mattern is they have a dense scar posteriorly that usually can't be fully excised with our endoscopic techniques. There's also the endoscopic wedge excision. And what you can see here in these pictures on the right are where parts of the scar are removed. You can see in this close-up photo. But parts of the scar with their overlying epithelium remains. And what I think happens in those cases is that these areas where there is some epithelium left and some disease allows for nests of that epithelium to overgrow the area that had been cut out. And what we find with the endoscopic wedge excision is that it's a longer lasting procedure than a regular dilation. Oftentimes it might be combined with SILC or serial intralesional steroid injections with the goal of further increasing the time between trips to the operating room. And then there's serial intralesional steroid injections. These have become very popular over the last 10 years. This is really an in-office procedure that's designed to complement or even replace OR dilation in successful cases. The steroid is injected directly into the scar tissue in the office, but we don't really have established protocols about when to give steroids. And it seems to work in a number of patients and then not in other patients. What I have here is a brief video that shows the needle coming through the neck, and then you're going to see that area of scar bleb up, and that is with the steroid or triamcinolone. And then we'll try and inject it into 3 or 4 different locations of the scar with the goal of the steroid reducing inflammation and then therefore reducing the amount of scar. In fact, as I mentioned, we really don't know who this works in. And one of the things we're very excited about at the moment is a clinical trial, the ASTRO trial, which is looking at that question of, do steroids work, and who do they work in? And it will be a 10-center placebo-controlled randomized double-blind trial. We are currently getting our final approval to start enrolling patients here at Hopkins, and then we'll activate 9 other sites around the United States. And the concept is pretty simple. There will be an index dilation procedure, and then 3 injections of either steroid or placebo spaced by 1 month apart after the index procedure. And then we're going to measure outcomes using peak expiratory flow at 6 months. So in conclusion, idiopathic subglottic stenosis can have a significant impact on individuals with this rare disease. We are making progress in understanding why it occurs, but it still remains idiopathic. And treatment options are all surgical and procedural, but may be tailored to the patient's goals and risk tolerance. I now want to make a transition to our question and answer session, which will be moderated by Donna Claire.
Thank you, Dr. Hillel, and thank you, Amy, both of you. That was fascinating, and there are a lot of questions for you. We're going to start with Amy. Allison has asked, when you were talking about the years you were misdiagnosed, how did the mystery or the invisible nature of the disease affect your mental health? And did you ever go back to your original doctors to let them know your correct diagnosis?
That's a great question. I think, yes, I think it definitely affects your mental health. I think something like breathing is something that you just take for granted every day. I still probably don't take it for granted anymore. You can't see it, so it definitely was anxiety. I thought it was all in my head. I was scared to cough. I also had a lot of these symptoms during COVID, so people would stare and look at you. And you can't see anything. I looked like a extremely healthy 38, 39-year-old, but you could hear me coming. So yes, it definitely affects your mental health. Even the process of going through all of the procedures definitely did. The support of Johns Hopkins and Dr. Hillel helped, but 100% that anxiety is there. And at certain times you think it's in your head. You have no idea. Yes, and I am an extremely strong advocate for teaching everybody who wants to hear about what I have, having them spell it out and write it down. So I did go back to my PCP as well as the pulmonary specialist and made sure that everybody knew what I had and those symptoms. Because if I can help even one other person get their diagnosis sooner, that is my goal. So great questions. I hope I answered them.
Thank you. And yeah, that's so important to help other people if you can. Dr. Hillel, we have several for you. Brenda mentioned she's had several surgeries since she was diagnosed, but she's not had any in-office injections. Should patients expect to have periodic surgical procedures for life?
In general, if you're going down the endoscopic pathway, I think outside of the endoscopic resection or Mattern surgery that I showed a video for, the disease tends to recur. And I think if you have a traditional excision and balloon dilation, even with steroid injection, the natural history of the disease is that it recurs at some point, I have some patients that are rapid recurs, and I would say less than a year. And I have some patients that are very slow recurs on the order of 5 to 7 or 8 years, even. Um, but I think some of the newer techniques, in-office steroid injections have elongated those times between going to the operating room. In addition, I think if you're somebody who wants to get rid of the disease, I thought Amy really described it well when she said this is like having a chronic disease. And I think what's so hard with idiopathic subglottic stenosis is how healthy all the women who have it really are. That's one of the things that stands out to us when we look for comorbidities. There are really very few in this population, and it's hard to wrap your head around having a chronic disease. And I think that if you're someone who is willing to take on some of the risks of an endoscopic resection or a cricotracheal resection, those are very effective surgeries when performed at a center that has experience doing them.
I think that what you have talked about during your presentation, Dr. Hillel, and the journey that Amy has been on points to the importance of research with this condition. And I'm the development director in the department, so I work with our faculty to help raise funds for their research. So we're going to go ahead and post in the chat the online giving link, which has my contact information too, if anybody would like to donate or contact me later to discuss. There was a kind of a technical question from Charlene. Can you predict how many, the timeline for how many dilations or how close together before moving to the next process, either the Madden or a resection?
I think for every individual, it's different. And my traditional approach has been to do an excision and dilation for the first surgery if I'm the first treating surgeon. Um, and then to see how long the natural course of your disease takes to return. And I think it will almost always return, and the data really shows that. At that point, if I usually break it down by individuals who are, rapid recurs of about a year, if not even a little longer now. Um, and then those that maybe go 2.5 or 3 years between needing surgery. And then at that point, I think once we have that interval that is usually pretty stable, I think I can give a better sense of how likely is it to come back. We probably about 10% of the time I see cases like Amy described where the first interval is the longest, and then it slowly but steadily or relatively rapidly in Amy's case, the times between surgeries shortened. And that's, I think, what led her to consider first joining our clinical trial, and then moving to some of the more definitive surgical therapies.
Couple of questions about the idiopathic versus others. One is, does the treatment for idiopathic subglottic stenosis differ from autoimmune or the iatrogenic?
The treatments can differ a little bit. I think that treatments like Silsy, and then the endoscopic wedge resection and the endoscopic resection or Mattern tend to be in the idiopathic group. That scar tissue behaves a little differently than when scar tissue is formed from a breathing tube or a tracheostomy. And then autoimmune disease, I think certain individuals with autoimmune subglottic stenosis, it's usually granulomatosis with polyangiitis, I think can be candidates for those treatments. But in many cases, they're well treated with systemic therapy. and their subglottic stenosis doesn't recur so quickly.
What is the difference between iSGS and idiopathic tracheal stenosis?
Yeah, I think they're one and the same. The idiopathic subglottic stenosis usually extends to involve the first or second tracheal ring, and that's where the idiopathic subglottic tracheal stenosis comes in, or idiopathic subglottic stenosis describes it as well.
Okay. Dr. Hillel, let's talk hormones. Couple of questions. Are there any specific hormones being studied for their impact with iSGS? And then another question was, might hormone therapy have an impact on those going through perimenopause?
Yeah, so I'll take the first question in terms of what are our lab and other labs around the country studying. We're looking at, estradiol and progesterone tend to be the two main female hormones, and we're looking at those in terms of, do they have an impact on the fibroblasts that make the scar? Do they have an impact on the skin that we think is contributing to the leaky barrier? And we are really at an early stage to determine what is happening there. The hormones don't seem to have a direct effect on the scars, on the fibroblasts, but we're looking at it for their impact on immune cells and epithelium, where they may. I think certainly. Though I'm told by many patients that there are times where they feel like their disease, that their breathing gets worse, and they attribute that to hormones, and I think that is possible. And then that leads into the second question of hormone replacement therapy or oral contraceptive pills. What I have seen in individuals who I've taken care of in my practice, and this is purely anecdotal, is that it can sometimes, both of them can sometimes affect the scar tissue or how quickly it comes back. In some cases, it can speed it up. In other cases, it can slow it down. And I haven't seen a specific pattern where I feel comfortable making recommendations on whether you should or should not take oral contraceptives or hormone replacement therapy due to its potential impact on iSGS.
Earlier in your talk, you were talking about genetics. Susie is wondering, how do you know if you have the mutation?
Yeah, I don't know that the mutation, I have a few theories on the mutation. One, this is early stages in that research. And if that gene is shown to have a causal effect, and that's one of the things we have yet to determine. All we've seen is that it's mutated at a higher rate in this population. Then there would be ways that we would probably pretty rapidly develop a way to test for it. But I think it's also possible that there are other explanations for that specific gene. And in addition, as you saw in the data we presented, looking at the intervals between surgery, some patients who have iSGS actually have a normal production of this gene. They were the ones that had the longer dilation interval. So I think we're still, again, I'll come back to, we're still at early stages in terms of what is the clinical import of this and how we would bring in testing for this mutation as a way to counsel our patients.
Amy, we have a viewer with us this evening who also was very athletic before this disease, which she's had for 4 years now. And she's wondering if your athletic life has returned to normal since your surgeries, or a new normal?
Yes, actually, Dr. Halal can probably tell you my very first question post every surgery was, when can I work out? How long are you going to have me recover? And I can 100% say, if anything, I am in the best shape of my life. I don't feel any effects. Sure, every time I get a cold or cough, it goes through my head. But yes, my athletic life is fully returned and I have zero restrictions. So if you're going through anything similar, hang in there. Take the time to heal and recover, and you can definitely get your life back, especially athletically.
Great. It's good to hear. Dr. Hillel, is there any current information on how climate or altitude impacts patients with this disease or the disease itself?
I think at higher altitudes, when your airway is narrower, it becomes, now you have a new variable that further limits your breathing. So that's something to consider. Um, in terms of climate, I haven't seen real patterns. One of the theories is that there is a particulate or something in our environment that maybe is part of that initial trigger. So maybe the antigen is not necessarily a bacteria or a virus, but it's a particulate. And I know that people have talked about looking at, say, pollution levels or other markers for how much particulate is in the environment, but we really have no studies on that at this point.
On the topic of impact, is there any impact on other organs as a result of the narrowing of the airway? Heart, lungs?
Yeah, in general, this really does not seem to manifest. There's no other system other than maybe adjacent organs like the vocal cords that are affected by the spread of the scar tissue. It doesn't seem to manifest anywhere else in the body, and in fact, that's one of the things that I will usually identify. If it does, it usually indicates an autoimmune cause. And so that can affect your nose, that can affect your ear, that can affect your lungs, your kidneys, your joints. And so if you have any of those symptoms and have shortness of breath, I would lean towards an autoimmune cause.
Okay. Is there any research or in your experience, a way to tell which procedure, the Mattern or the resection, is the most effective or more effective in the long term?
Yeah, I think we have more data on the resection. And the resection um, is a very effective surgery. I think that when you look over the long term, which and honestly is 12 or 15-year outcomes, there is a small chance of the scar recurring, but it's about 10%. We don't have data out that far for the endoscopic resection or the Mattern. Those numbers of the 25% is really an initial recurrence. And I think those of us who've been performing the surgery are just getting to a point where patients are getting at or over 10 years. And so we will see about the long-term recurrence rate.
On the topic of research studies, are there any concerning the fiber scar tissue that attaches to the vocal cord? Vocal fold.
Yeah, I mean, we are looking at that. There is a subset of iSGS patients who have a more aggressive phenotype, and when it grows up and involves the vocal cords, that can really, really be impactful because now you can actually have a second level of narrowing. And those individuals tend to fit into that more severe phenotype. I think the surgeries that are now available, especially the endoscopic resection can be very helpful in those cases, but we just have to extend the stent a little bit higher to treat the scar that's there at the vocal cord level.
Another question on research, very important. Have there been any studies on stressors?
Not that I'm aware of. That's a that I'm going to jot that down and see how we can add that variable in.
Thank you to Susie. I have a question. Somebody asked me a question, which is, how much am I trying to raise for Dr. Hillel's research? I'm the fundraiser, so how much do you have? But the bottom line answer is truly, really, any amount does help Dr. Hillel. It allows him to hire part-time or full-time people to help continue the research while he is busy seeing patients and helping patients in clinic and the OR. So, the sky's the limit, but thank you for including me. Lauren is asking if the throat clearing and mucus is still an issue post-resection.
Post-resection, because we are using the natural skin of the larynx and the trachea, it doesn't tend to be, from my perspective. I'm going to actually turn it over to Amy and ask about her experience.
Yeah, I actually never throat clear, rarely have any mucus secretions post-resection. Honestly, the hardest part of the resection surgery is the surgery and that initial recovery itself. Once you're sort of past that, it is really remarkable. Yeah, I'm pretty good with my diet. I, don't eat a lot of dairy, which some people say can lead to it, things like that, but that's a personal preference. But nope, I don't really have any throat clearing at this point, so it's pretty remarkable.
Well, keep yourself unmuted, Amy.
Oh, okay.
Let's see. Cindy is asking, I'm just going to read verbatim, it's a little long. Besides the quick diagnosis, was there a specific way that Dr. Hillel or the team spoke to you during your first consultation that made you realize that you were finally in the right place? And can you give some advice what other patients should be looking for in a care team?
I will try to make this short because I speak praise of Dr. Hillel all the time, as well as my family and everyone that has met him. I think it's the way and ease that he sits down in front of you, makes you feel like it's just a one-on-one conversation. He doesn't make you feel rushed. Any question you ask, he takes the time, and he really made me part of my treatment decisions. So it was always a discussion on if I wanted to continue dilations, if I wanted to move to the next step. And I think 100% my answer is if you're going through this, you want to be with a doctor and a facility that you are comfortable with. I never went into any of my surgeries worried. I knew I was in the best care and that we would handle it as a team, irregardless of the outcome and what happened.
Thank you. On that note, let's have that be the last response, which was fantastic. Thank you, especially to Amy for joining us. It is rare that we have a patient who is willing to come and share their journey and be put on the spot and answer questions. And of course, to the fabulous Dr. Hillel, who is treating patients with this condition, and it's a passion of his. Thank you also for coming. But most importantly, thank you all who joined us live online. There will, since the Hopkins at Home people have your email addresses, you will receive a link to the recording so you can listen to it again or share it with other people. And Hopkins at Home at Hopkins has lots and lots of, not just in their inventory of their library on their website, but also upcoming programs. So please continue to check that out and join us in the future. Dr. Hillel, do you have any parting words?
I would like to thank everyone for spending time with Amy and me this evening, and to say good night.
Thank you. Bye-bye, everyone.